The knee joint has three joint surfaces. Firstly, the patello-femoral joint, and the medial and lateral tibio-femoral condyles. Inside the synovium, there are two discs called menisci, which act to support the both surfaces of the joint. There's no synovial capsule to speak of, and the synovium is free to move underneath the quadriceps muscles anteriorly. There are also gaps or bursae posteriorly that allow the synovium to form these structures further up the joint called the bursae. These bursae are prone to inflammation. The joint is innervated by the tibial and common peroneal nerves, that's common fibula or peroneal, as well as the tibial nerve, which, don't forget, forms the sural nerve just behind the knee, as well as the femoral and obturator nerves. So it's femoral, obturator, common fibular or peroneal, and tibial nerves. Blood supply is from the genicular anastomosis, which is the anastomosis of 5 different blood vessels of the thigh. The patella is a sesamoid bone within the tendon of the quadriceps. The patellar tendon, or ligamentum patellae, then joins it inferiorly to the main bone of the lower limb, the tibia. The posterior surface of the patella becomes incorporated into the knee joint, as you can see on the lateral sunrise view, so-called sunrise view, in X-ray, which shows the patella like this. This is looking upwards towards the flexed knee joint, along the length of the tibia. The patella has a condyle on each side with a vertical ridge in between them. And when you look at it on X-ray, the joint is asymmetrical as a result of a more anteriorly projecting lateral condyle of the femur. The patella is pulled up by the quadriceps tendon, well above the space between the two bones, and can appear as dramatic as this if the quadriceps are in a state of full contraction. There's a tendency for the patella to dislocate laterally and upwards because of the very strong pull of the vastus intermedius and vastus lateralis, compared to the vastus medialis, which is not as powerful. This tendency is opposed or normally prevented by the elevation of the lateral condyle of the femur in comparison to the medial condyle, and that the tendon of the vastus medialis inserts into the lower border of the patella here to oppose the action of the other muscles. And the potential for dislocation can be made worse in osteoarthritis because it's the bone here which prevents the dislocation in most cases. The coronary ligaments of the knee connect the menisci to the bone below it on the marginal tibial condyles. As the knee extends, the two femoral condyles glide over their tibial surfaces corresponding to them until there's no more femoral condyle left to move over onto. The medial side, however, is larger, and this can extend slightly further than the lateral side. Because the surface is curved, it slightly medially rotates the knee joint, medially rotating the medially rotating the femur against the tibia, causing the ligaments to become closely packed. At this point, the joint is said to be locked. The knee is locked, and only the popliteus muscle can unlock it. Popliteus muscle is here. This picture showing the back of the knee causes a lateral rotation of the femur against the tibia in opposition to the medial rotation provided by locking the knee to unlock the knee. It's supplied by the tibial nerve, this is a view of the knee side on. The patella is held on by the patellar tendon to the fibula, tibia, and the quadriceps tendon above. On the medial side, between the two medial condyles of the femur and tibia, is the tibial collateral ligament. Would be the other side, but this shows the lateral side. On this side, you'd see the fibular collateral ligament between the lateral epicondyles and the iliotibial tract, which remember is a reinforcement of the fascia of the thigh that goes down and actually connects part of the knee joint. The tendon of biceps femoris attaches into the top of the fibula, or just the head of the tibia, but near the joint with the fibula. And in this sort of area on the other side, you'd see the attachments for the quads, for the other hamstrings, the gracilis, sartorius, and semitendinosus. The only hamstring being the semitendinosus, and the other muscles are the gracilis, sartorius, and sartorius muscles on the other side of the bone, but in this region. The cruciate ligaments are those inside the joint that connect the two bones. Popliteus will be seen going across here, with the arcuate ligament going over the top of it and then splitting out into a Y shape. And then the two collateral ligaments either side. Got the lateral one here. To add to all this are the patella retinaculi at the sides of the patella, and the pes anserinus, pes anserinus is the word for the combined tendon made from the sartorius, gracilis, and semitendinosus muscles. Now these ligaments, plus the ones on the previous slide, contribute to the support of the knee joint, all of these together. And to test that they're working, one can straighten the limb, which bunches all the ligaments up and makes them tighter, in the locked position, and then by abducting the leg whilst holding the knee, this tests the integrity of the medial collateral ligament, and then pushing inward to test the lateral collateral. If an uneven stress is placed upon the knee joint and supporting structures, the centre of gravity is transferred from the medial to the mechanical axis, and the leg is said to be bowed. Genu valgum places stress on the medial collateral ligament, and genu varum places stress on the lateral collateral ligament. One reason for the development of these conditions is weakness of these ligaments initially. The cruciate ligaments of the knee are twisted in an X shape between the two bones of the knee joint, and are therefore placed under great stress when the limb is fully extended and the knee is locked. The anterior ligament is more delicate than the posterior one, since it's thinner, and both are highly vascularized, leading to possible hematoma if they're damaged. The anterior ligament travels roughly anterior to posterior and medial to lateral, and the posterior the other way round. To test for damage, bend the knee around 80 degrees so that the hamstrings are relaxed, and if the tibia is displaced anteriorly, shows that there's some damage to the anterior ligament, and if it's displaced posteriorly, it shows damage to the posterior ligament. The anterior ligament extends from the head of the tibia to the intercondyloid notch of the femur. The cruciate ligaments, however, are not part of the joint cavity itself, so they have a blood supply. The knee is surrounded by fluid-filled sacs called bursae. They're the weak points of the joint, and can enlarge if the joint is swollen. They are the Suprapatellar Bursa, the Popliteus Bursa, which sits under the popliteus muscle, the Gastrocnemius Bursa, which sits under the semimembranosus hamstring muscle, and finally the Anserine Bursa, which sits between the pes and serenus, which is the sartorius, gracilis, and semitendinosus membranes, and superiorly the tibial collateral ligament, or just underneath. It's just superior to the tibial collateral ligament, which would run here.